Welcome to the webinar. My name is Mapuana Taamu, and I am the presenter for today. I will be presenting on dementia, normal versus not normal aging. The philosophy that I use is the positive approach to care, which was coined by a woman named Teepa Snow. And I have a bio about her. But before we get into that, I need to introduce HPGS, Hawaii Pacific Gerontological Society. And yeah, so HPGS is a nonprofit, and the goal of HPGS is to enhance the general well-being of older individuals in the state of Hawaii and the Pacific Islands by doing a few things. So we foster public understanding and continuing education in the field of gerontology, bringing together all people concerned in challenges, issues, and problems of the older adults, or kupuna. We also advocate on behalf of older people in Hawaii and the Pacific Islands. We stimulate interest in research and services, encouraging professional preparation for gerontological research and services. And we also promote volunteerism in the field of gerontology. So I'll just show you real quick. This is hpgs.org. So if you just go into your browser later on, hpgs.org, we got a bunch of things in here. If you're not a member yet, there is a membership tab at the top. Check it out. I will be posting this webinar on YouTube after this, and I have all your emails, so I will send you an email when that happens. And then there's also on hpgs.org a tab for webinars, so we will have it on our website for quicker reference after her. Teepa Snow, who started the positive approach to care, she is one of the leaders on education about dementia throughout the nation, and I think Canada. Her philosophy is reflective of her education, her work experience, medical research, and firsthand caregiving experiences. She worked as a professional or an occupational therapist for over 37 years, where her wealth of experience led her to the development of this positive approach to care technique and training model that now helps families and professionals worldwide working or living with people with dementia or other brain changes. She's an advocate for those living with dementia and has made it her personal mission to help families and professionals to understand how it feels to actually be living with the challenges and the change as a person living with dementia instead of from the caregiver's eyes. So her company, the Positive Approach to Care LLC, it was first founded in 2003, and it offers education just like this to family and professional caregivers all over the world and now here in Hawaii. There's also a few other PAC trainers, and you will be seeing one of my friends that also teaches a positive approach to care. I have a video if everything goes smoothly. You will see a video of us. Okay. So now I can introduce myself. Got to keep time here. So I'm Mapuana Taamu, and I've been working for about 7 years directly with people living with dementia at Halikuike. So Halikuike is an adult residential care facility or care home that is licensed by the state, and they specialize in memory loss or memory care, dementia. And I've been working there for 7 years in the activities department as well as the nursing department. And from the way I look at it as activities is like the emotional, the mental part of dementia, and nursing is the physical, outer exterior, wounds and whatnot, the aspect of dementia. So you put those two together, and that's a positive approach to care. And that's why I jumped on board. So let's see, I didn't write the learning objectives, but I have 4. So the first one, I will teach you a little bit about dementia. I call it Dementia 101. It's just a brief overview of what is dementia. The second one is, I think I'm going to show you 2 skits, 2 role plays of Teepa Snow. She's going to be acting out what is normal aging and what is not normal aging. And then hopefully, you folks know how to use the chat box. I was hoping that this would be a little bit more interactive. So we're going to try to utilize the chat box. I have a few polls I wanted to try out. Just playing with it last night. It's kind of cool. So if you can, type something into the chat box. Let me know you're here. Say hi. Tell me your name. I'm not going to shout you out. It's okay. It's just that I can't see you. And hopefully you can see and hear me. And I can't hear from you. Aloha from Kona. Thank you. Okay, I'll get started while you folks get acquainted with Zoom. So I wanted to start off with, what do you think is dementia? When you hear the word dementia, what other words come to mind? And I have a poll for that. So we'll try that out. I'm going to launch the poll and it should pop up on your screen. It should be there now. So when you hear the word dementia, I only put a few answers. I couldn't put them all. When you hear the word dementia, choose the 2 best answers that come to mind. Wow. And then I can show you the results afterwards. It's live, it's cool. Wow. So about half of the entire audience has voted. We have 35 people tuned in. 23 are done, voted already. Maybe about 10 more seconds. I mean, there's no right or wrong answer. You have logged in from another device. Messenger is now inactive. No. What does that mean? Kalika, don't log in. So I'm logged in as Kalika. Oops. Hold on. I'm going to call her. You did? Okay, yeah, because everybody could hear you. I just logged off, sorry. Now I got to figure out how to put my audio back on. It's cool. But you can see me? Oh, okay, everybody can hear me. Hello. Okay, cool. Bye. So obviously I'm not Kalika Ishal. She is, I think, at home taking care of some business she has today. So she logged in and logged me out, but I just called her and everything's good. Okay. Wow, surprised that's all you can see. So the highest percentage with 69 is memory loss. Second highest is cognitive impairment, and then Alzheimer's disease. Perfect. So in the chat, if you can write down different diseases that come to mind when you hear the word dementia. There's Alzheimer's disease, that's the most prevalent one. Lewy bodies dementia. Oh, that one is more common than I thought. I got 3 Lewy bodies. Interesting. Syphilis, aphasia, okay. So some other diseases, we'll go into it a little bit more later on, but I heard Lewy bodies, TIA, okay, that's vascular. That's more common than I thought. Parkinson's related, great, so we're all on the same page. So when you hear the word dementia, we might think dementia equals Alzheimer's, right? Because according to our poll, we have memory loss, cognitive impairment. And then Alzheimer's, we think equals memory problems. And yes, that might be true, but let's switch slides. With dementia, it doesn't necessarily mean you have Alzheimer's. Oh, I gotta take the poll off. Cool. So dementia does not necessarily mean that you have Alzheimer's, and Alzheimer's doesn't necessarily mean you have memory problems. You might have memory problems. You can't see me. You might have memory problems. You might have language issues. You might have judgment issues. It's not just memory problems, in other words. So here we have dementia as the umbrella term. meaning that it's the main category. And then there's on the bottom of it, the different types of dementia. So I like metaphors. If we can relate dementia to the word flowers, and then under that, we have the different types of flowers, right? Marigold, roses, violets, tulips, hibiscus, right? So dementia is a category, meaning that these are the symptoms of cognitive impairment, the symptoms of something that's going on with your brain. And through those impairments in the brain, we have these diseases. And of course, it's categorized because not everything affects your brain the same way. For example, vascular dementia, that is strokes. And as we know, we can have strokes in any part of the brain. So if it hits the left side harder than it hits the right, the left side is where we keep language. And with language comes with speech production, vocabulary, and comprehension. So if it hits that left side, that's why we have people after stroke, they need speech therapy to speak again, because it hits that left side, that language portion. On the right side of our brain is the rhythm, racial slurs. This is a fun side of your brain. What Teepa Snow does in order for learners to understand and better retain the knowledge, she likes to do funny things. So we take both hands, and hopefully you're at a desk by yourself, or if you're around peers, have them join in too. It's just a way of learning better. So we have the left and the right side. The left side is where we keep language in our brain. The right side is more rhythm, fun things, music. That's the right side. So what Teepa says is, and please do it with me, language on the left, rhythm on the right. Language on the left, rhythm on the right. So language is here, rhythm in here's. Language is lost, rhythm is retained. And we might talk about a little bit more. But what I'm trying to get at is that dementia, those symptoms, it equals brain failure. The person's brain is dying. Just like any other organs in the body, we have organ failures like liver, kidney failure. All those things are lung failure. Those are different organs that are failing, and dementia deals with the brain. And that's a little bit more difficult, I think, as caregivers to understand that it's brain failure, because if I relate it to other organ failures, the lungs, if someone has chronic obstructive pulmonary disease or lung cancer, something's going on with the lungs, it's going to affect your breathing. So a person with COPD, you might see is hunched over, taking short breaths, shallow breaths, and you can't really see them hunched over. They might have an oxygen tube, but what I'm really trying to impress upon you right now is that you can see what it does to the physical part of people. You know, they're hunched over. You wouldn't walk with your mother with COPD and she's lagging behind. You won't tell her, come on, let's go. Why are you taking so long? Hurry up, we need to go now. You understand that she can't because her lungs are failing. And you can see that she's getting tired and that she can't walk much longer and that you need to take a break. And it might be annoying, but it's understandable. Now with dementia, their brain failure results in behaviors, acting things out. That's why we have these challenging behaviors with people with dementia. And we think that it's annoying as caregivers. Because why can't my mom just put on this shirt? Or why can't my mom feed herself? Like, it's simple. You just pick up the spoon, put it to your mouth, just feed yourself. Why can't she just brush her teeth? Why can't she? Because brain failure. Next. All right, let's move on. So 5 truths about dementia. At least 2 parts of the brain are dying. It's very individual. which two parts are of the brain are dying. They say if you meet one person with dementia, you've met one person with dementia. And that person is individual. They have different parts of the brain that are dying, different ailments. They might have, you might have a UTI at the time while having dementia, while having high blood pressure, high cholesterol, needing vitamin B. You know, there's other complications. It's not just dementia. But when you do have dementia, at least two parts of the brain are dying. We don't know which parts. Usually the left is attacked more severely than the right. So that's why you lose language first and you retain rhythm. And we can use rhythm to really help these people with dementia since language is now lost. But another truth about dementia is it is chronic and it cannot be fixed. There are medications that help with dementia, but it doesn't fix it. What I understand is that like Namenda and Exelon, all these dementia medications, what they're meant for is to like help the brain produce chemicals at a stable rate so that there's not too much of an influx of behaviors throughout the day. If you can more or less control the chemicals that are acting on the brain, then you are more able to, I think, I mean, I could be wrong, don't quote me on everything, but if you can control more of the chemicals going on, then the more behaved they would be, the more compliant, the less resistive. I think it's more due to that, while the brain dying. But anyway, dementia, I'm sorry, is progressive and it will get worse. Unfortunately, it is terminal and currently there is no cure. So dementia and the brain. Dementia is both a chemical change and a structural change in the brain itself, what's going on up here. So chemical changes, they are variable. That means that throughout the day, like I was doing this motion earlier, if you want to stabilize that variation of chemical change, that's when you have more compliant residents, since I work at a care home. But it is an influx and it's difficult to manage. Anyway, chemical changes, it's like a wash. Your brain is washing in chemicals all day and it varies. Sometimes people living with dementia can really shine when they get a chemical rush, when they get that one chemical that they need to be bright. At the care home, I see in the mornings, they are more sharp than they are in the afternoons. After breakfast, I guess after they've got a well night's sleep, they've got their brain juice, Ensure, whatever they need to start their day, that's when this chemical rushes. And it lasts for, I would say, a few hours. We do exercise and then we do something to stimulate the brain. So we do this game called Categories or Alphabet Challenge, things that stimulate the brain. So I get them going with exercise and then we work the brain a little bit, take a break for lunch. And after lunch, it's like they have expended all the energy that they attained last night with sleep and food. And now they need food and sleep again to function better. And it's just like in the afternoon, they go down and they take their naps. And we see a lot more sundowning. So I would say that in the morning, the chemical change is high. And then towards the ending, the evening time, when they're sundowning, it's just really low. And that's when we need to use the positive approach. With the structural changes in the brain, these are permanent. The actual brain itself is actually dying. Cells are shrinking. And that means that symptoms will come and go. PLWD, people living with dementia. We don't like to say demented. Sorry, somebody asked a question, that's why. So people living with dementia, thank you for asking. Sometimes the person living with dementia can, and sometimes they can't. Like I was saying, in the morning and in the afternoon. They can in the morning and they can't in the afternoon. Could be vice versa if they're nocturnal. But what I wanted to get with this one, this is a picture of two brains. This is a picture of two brains that were donated to, I think, the University of Colorado. I keep getting that mixed up. But anyway, one of them is a normal aged brain. The other one has Alzheimer's or had Alzheimer's disease. These are both from males around the same age. And at the time of death, their skull circumference was the same size. Thought that was an interesting fact, but that would just mean that the brain didn't have the space to grow bigger, you know? So anyway, the normal age brain and the person living with dementia's brain, Alzheimer's. I wanted you to chat, send me a chat, and with the question in mind, when you see these two brains, what are the differences? Seeing them side by side, just visually, what do you see that's different? We're talking about structural changes. So structurally, what do you see different between the two? Less mass on the right one, smaller and darker. One is smaller. The color, yeah. So one is a little bit darker. It reminds me of smoker's lungs. More spaces, one shrank. Yeah, so perfect, thank you. The normal brain is definitely more juicy, I like to use. And the one on the right, we see a lot more spaces. I would say Grand Canyon. It definitely shrunk. And the interesting fact about this picture, from what I've heard, the facts, is that the person living with Alzheimer's, their brain is 1/3 of the mass than the one on the left, or the normal age brain. It's 1/3 of the mass, but it doesn't look like it's 1/3 of the weight or the mass, right? It doesn't look like that's the size of 1/3. So where do you think that extra mass is missing? We see that there is more spaces on the inside. So on the inside of the brain is really what's being affected the most. And that's where it really counts. So these are two pictures of the brain, different parts. I forgot which part is what. I had a paper for that, but I have too many papers right now. But what I want to emphasize right here is the structural changes. So we see that even the outsides, I can't point. Can I point? The outsides here are shrunk. And from what I know, I don't know much about the inside of the brain right now. I know the outside. And the outside, remember I said left is language. Here is more significantly attacked than the right side. So their language comprehension, their speech production, their vocabulary, it went downhill much faster than the rhythm on the right. The music, the melodies, that's what we can reach because language is gone. I'm sure the one on the right has a hole in it, and that's the memory center. So yes, memory is affected by Alzheimer's and the different types of dementia. It just depends which dementia you get. That'll dictate which parts of the brain are dying. All right, mimics of dementia symptoms. This is important to talk about because depression and delirium, they can really mimic symptoms of dementia. So dementia, you can't think, you can't remember. You might lose interest in things and say it's not worth it. Loss of function, you don't know how to control your bowels. You can't really control your emotions. Mood swings, personality change in sleep. With dementia, you might sleep more in the day, more in the night, due to not knowing time and place. And those are all symptoms of depression. Depression as well, you can't think, you can't remember, your brain it's not working the way that it's supposed to, you have loss of functions, you might be more lethargic and stay in your room, think things are not worth it, your personality change just goes down, and you might have changes in sleep as well. So, perfect example of depression mimicking dementia. And with delirium, that one is really a swift change in behaviors. So more confused if they have delusions or hallucinations, they're seeing things. If they're having on and off responses, it might be due to an infection. At the care home, we see a lot of delirium with urinary tract infections. It sometimes makes them hallucinate, delusions. What I've seen a lot of is their legs get shaky and they can't really bear their own weight. They get really afraid. It could be due to toxicity, and it is very dangerous. Before I get into toxicity, if you have a UTI, let me see if I'm keeping time. If you have a UTI, you are prone to sepsis. And I learned that with one of my residents. So there was a urinary tract infection, and sepsis means that the infection spreads throughout your body. So that's very dangerous because your body can shut down. And that's why you need to get it checked out real quick. Delirium. So that delirium is swift changes in behaviors. One day, she could play bingo. She knew where to put the chips. The next day, she's asking, where do I put the chips? And instead of waiting, she covers them all before they even start. And her fellow table mates are getting mad because that's not how you play. They know how to play and she doesn't. But yesterday, she could. That's what I mean by swift changes. Also, if it is an infection, take their temperature. A lot of times with UTIs, people with dementia, they lose sensations, so they can't really feel pain when they pee. As a normally aging person, we will feel pain with a UTI when we pee. People with dementia, not so much. So they won't act out as I have pain there. Or if they do, they might punch you and not let you touch their private part, but they can't tell you that it hurts. So what we do is take their temperature, and if they have a fever or they're getting high up there, then it's possible, get a urinary or a urine analysis, get that checked up. But with this slide, depression and delirium are both treatable. Dementia, not so much. That's why this next slide is important. If you do notice changes, you should get an assessment, go to see the doctor. Because if it's depression or delirium, that can be fixed. There is antibiotics. There are therapy sessions they can go to if it's depression. They have medications. I mean, there is something that we can do about it. But with dementia, there is no cure. We just have medicine, from what I understand, we just have medicine that helps regulate brain waves or brain chemical fluids throughout the day. That's all we got so far, besides care. That's what Tipa likes to say. In the back of my shirt, it says, until there is a cure, there's care. So before there's a cure, positive approach will teach you how to care. All right, that's the end of my Dementia 101. Now I wanted to show you a role play of what normal aging looks like. And there will be a video of Tipa Snow playing pretty soon. I gotta open it up. So hold on. If you have any questions, I can try to answer them. Oh, wrong button. Oh, shucks. Love your shirt motto. Yeah, Tipa Snow, man. Oh, if you just want to check out Tipa Snow later on, her website is pretty easy. It's tipasnow.com. tipasnow.com. Right, new share. So here is Tipa Snow. You may or may not have to adjust your volume. That's interesting. Okay, here we go. T-E-E-P-A. T-E-E-P-A, Tipa.
What we're going to talk about now is the difference between normal aging and not normal aging. Now understand, I did not say dementia. I just said normal aging, not normal aging, because one of our big misconceptions in this country is that if it's not normal aging, it's going to be dementia. And that's not true. So we've got to get that one off the table. So what I'm going to do very quickly is give you two quick little role plays that are going to take you through normal versus not normal. So I'll do normal first. I'm in the living room, and I've been watching a TV program, and the program finishes, and I decide, you know what? I'm thirsty. I think I'm going to go make a pot of coffee. And I head toward the kitchen to make coffee. But before I get all the way in the kitchen, the telephone rings. And so I answer the telephone. Hello? Oh, hey, sweetheart. How have you been? Well, yes, of course I know who it is. It's, right on the tip of my tongue. Starts with a B. Betty, of course it's Betty. Sorry. Recognized your voice right away, just couldn't think of your name. Yeah, senior moment. Huh? What? Oh, no, I'd love to get together. Oh, today? Okay, what? At 2 this afternoon? All right. Oh, at the mall. Okay, well, which end? Macy's. Oh. That's where J.C. Penney's was, right? They moved out and then I know where you're talking about. Absolutely. The menswear, is that the same? Yep. I know where to be. 2:00, I'll be there. Wait right inside the door. I'll be waiting right inside that door. It's supposed to be a little chilly this afternoon. Yeah. Huh? What? Oh, they opened a new chocolate store. Oh. Well, you know me. You know what I'm going to get. I'll get caramels. I always get caramels. You're going to get, I know you like the white flaky stuff in the chocolate. Yes, coconut, of course. That's you. Huh? Oh, no, I'll be happy to call and see if Margaret wants to come. That'd be great. Yeah. Oh, the vacation pictures? Oh, yeah, I'll bring them. Wait till you see yourself in that bathing suit. Oh, I was just kidding. Just teasing you. You know how I am. Such a teaser. She's getting fat. I'm not going to say it, but she sure is getting fat. Okay. Huh? What? No, I didn't say anything. I was just talking to myself. Writing a note. All right, sweetheart. Well, I'll see you then. Love you. Okay. Bye-bye. What did I come in here for? Okay, hang on. Let me think here. I was in the living room. I was watching the TV. Program ended. Hell, if Betty hadn't called, I'd been able to do anything on this. Okay. I was in the living room. I was sitting right here. Okay, and the program ended, and I thought, man, okay. Coffee. Why could I not think of that? Lord knows I'm losing it. Now, all of you've gone dead silent because all of your brains are going, oh shit, I have this. Every single one of your brains is going, oh my God. And your brain is going, that's not dementia. That can't be dementia. I don't think that's dementia. That's just normal. Isn't that normal? I think that's normal. Your brain is talking to itself. One side is going, I think you've got, no, she didn't say that was dementia. I think she said that was just not normal. I think that was okay. That happens every single time. The room gets dead silent because if you just think old people are worried about this crap, no, we're all concerned. Because you're going, I think I've done that. I did that just yesterday. What you've totally forgot, because in that moment your brain was going, is I said that was normal. I was going to do normal first. See?
Okay. Okay, hello again. So, I hope that was funny. Old Mother Hubbard went to the cupboard. Now, what did I come here for? That's the message that Teepa was trying to send. I want to chat for a little bit. So if you can relate to this, let me know. Have you ever had that instance? Maybe it is at home and you want some coffee or you want a snack. So you get up from your computer and you go into the kitchen, but along the way you put the mail away or you grab your clothes to go back to your room, or you do something, in other words, and you get into the kitchen, you're like, what am I here for? Almost every day. Yeah. I mean, I'm 24 and that happens to me almost every day too. Definitely. So in the chat, why do you guys think that this happens? Why do you think that from our room to the kitchen, we can't remember that I wanted a Danish or a cup of juice? Distractions. Definitely. Me too. Sometimes too many things on our minds. Yeah. Brain overload. Where did my paper go? So multitasking. That's exactly what I was just going to say. Usually when we're stressed out as well. So this is due because we get so stressed out. Oh, what am I trying to say? It's kind of like when you're driving and somebody cuts you off and then you're distracted for a little while and you just get so mad and you can't hold it in anymore. It's just like cortisol is dumping into your brain and our bodies get so aggravated and we can't really think straight with all these distractions and we're multitasking. Our working memory is not so large. And so when that happens and we're stressed out, we take some deep breaths in. So if you could with me, just let's calm our bodies down to bring our cortisol level down. And that's when we can think again. Another situation that this might happen is if, like, you walk into your mother or a resident and there's BM everywhere, your cortisol level just jumps through the roof. So what do? In order to calm yourself down, bring down the cortisol, we got to take some deep breaths in. So let's take some deep breaths in together, if you can. So with me, take a deep breath in and out. One more time, deep breath in and out. I think I needed to lower my cortisol just then. So let's recap. Normal aging. You, as a normal aging person, are slower to think, we're slower to do, and we may hesitate more. So going back to Teepa Snow's skit, she knew the person when she picked up the phone, but she could not find the name. She said, I know your name, it's on the tip of my tongue, it starts with a B. She could get that much, but she couldn't get Betty until the person said Betty. And she's, yes, that's right. So she could connect. New data reminds me of old. With normal aging, we are able to, especially in Hawaii, navigate our way around using landmarks. So like Teepa Snow said, Macy's. Now I don't think there's a Macy's in that mall. Oh no, that's where the JCPenney's was, right? So we actually wrote a local version. Wow, my time is just flying by. We wrote a local version and we wanted to relate it to Ala Moana, the Sears store. So you know how there used to be Sears, but now it's Nordstrom? Yeah, we use landmarks, but new data reminds me of old data. I can make that connection. With people with dementia, cannot. She was having trouble recalling a word. If you remember when she went to talk about the coconut, she said, I like caramels and you like the white flaky stuff with the chocolate. She couldn't say coconut, but she could describe the word enough so that the other person could get it to pop. So what we call this is circumlocution. Put your thumb up, that's a noun, and we want the noun to pop. We're trying to find the noun, but we can't find the noun, so we circumlocate right around it. We're trying to find the noun and we use the words to describe it. So white flaky stuff with the chocolate, coconut. That's how she did it. And that's how we do it as normal aging. We describe things. I know your name. You were the one that I met at Ala Moana and we went to get gelato and you were right there and my bill was $3.17, but you can't think of his name, but you can describe it pretty well too. People with dementia, language is lost. They can't really describe things as well. What time am I supposed to finish this? Oh, I'm on time. Cool, I think. So, what's next? Sorry, may pause when finding a word. She took a long time to find white flaky stuff with the chocolate. She's more likely to look before she leaped. And that relates to impulse control. So when she was on the phone with her friend Betty and she said, oh, those vacation pictures, she said, when she put the phone down, she said, boy, she sure is getting fat. I'm not going to tell her, but she sure is getting fat. So she picked up the phone and said, what? No, I'm just writing a note. And in that instance, she had the impulse, she had the filter to know that if I say this to Betty, it's going to hurt her feelings. So I better put the phone down and say this to myself because I need to get it out. I need to get it out and I don't want to hurt her feelings. So I'm going to say it and then come back. We take that time out to do so. But that's because as normal aging people, we have the filter to do that. We have the impulse to do that. On the other hand, people living with dementia are not able to see the other person's perspective, but we as normal aging people can. So I'll do a flip side example. A person living with dementia might tell you something mean like, wow, honey, you're looking fat today. Have you been eating because you need to stop that. I'm just saying, you look like you put on some weight, you know? And as a recipient of that comment, you might get really aggravated or even sad, like, and you're going to show these emotions, right? But the person living with dementia, they don't see your emotion. They just see you, and they don't see that you're affected by this. So they just keep going on and on and on and on. Yeah, it's kind of sad. I hope that was enough of a recap for the normal aging. I wanted to show you now what not normal aging looks like. So let me find it. There you are. It's going to be Tipa Snow again. And yes, and she is going to do the same scenario, the same skit, but from a perspective of somebody who is not normal aging. And we say not normal aging because it might not be dementia. There's other things that affect the brain that could relate to what's going on. So I found it. Let me just share your screen. Share. Check. All right, I'm gonna stop my video, but you can still hear me. And here's Tipa Snow, not normal aging.
I'm in the living room and I've been watching TV and the program ends and I said, well, you know what? I think I'll go make something to drink. I want something. I'll make some of the stuff that you get. That's it. Gonna make it. Phone rings. Hello. Hey, sweetheart. Yeah. Mm-hmm. Who is this exactly? Betty who? Oh. Well, why didn't you say? Okay. Well, what do you want? Me today? Why do you wait till the last minute? I wish you'd tell me ahead of time. Well, I don't remember you talking about it at Bridge. Did you talk about it at Bridge? Well, you talk all the time at Bridge. Your mouth runs incessantly. Huh? Well, okay, I don't mean to be mean, but you just talk a lot. That's all. What? Oh, you want to meet at the mall? Okay, well, that's fine. Which end? 2 o'clock? Yeah. Macy's. Well, honey, I don't think there's a Macy's at that mall. Where's there a Macy's? No, that's a J.C. Penney. It's a J.C. Penney's. I have a card with them. I have a credit card with them. I know what it is. I buy things there. What do you mean they moved out? No, I shopped there not long ago. There's no way they moved out. Did they just close up? Well, good Lord. No, that's still, you sure? I think you're wrong. Well, fine, I'll meet you at that end. I know where you're talking about that. Huh? Inside the men's, well, of course I know where inside the menswear is, but you better get to the right store. You're not going to be there. Huh? All right, well, fine, whatever. What? Oh, they opened a chocolate store. Well, you know me, I love that. That's my favorite. What? Well, I'll have caramel, and you'll get the, oh, you like the kind of brown hairy ball and the brown stuff. What do you mean, what am I talking about? I'm talking about the brown hairy ball kind that you like. You like the brown hairy ball. Do you speak English? Honest to God, get what you want. I don't give a shit. I mean, whatever. I will start arguing about this. Huh? Well, no, I'll call her and see if she wants to come. That's fine. What? The vacation pictures? Oh, about on the boat? Yeah, I'll bring them. Wait till you see yourself in that bathing suit. Well, honey, you look like a cow. No, I'm telling you, your butt cheek is hanging out so bad. I mean, it looks, I mean, you must have put on, what, 30 pounds? I mean, you're eating too many of the brown hairy ball things. That's what's going on. I mean, that's all I can tell you about it, because you got to be sucking them down because the way it's coming. Well, if you don't like looking the way you look, you should do something about it. That's what I say. Well, listen, do you want to get together? You're going to get an attitude. Well, then I'll see you there too. That's fine. I don't know why you're so stirred up. You're the one eating. All right, then. Shit. I mean, I don't know what her problem is. Lord, she gets an attitude. Now, let me think here. Oh. A dirty cup. A coffee cup. Now, I told my son that I was fairly sure that gypsies were coming in here at night and making coffee, drinking my coffee, and leaving dirty dishes, because I've never left dirty dish in my life. And here it sits, a dirty coffee cup, partially drunk out of. I'll guarantee this has their prominence all over it. And I better go check the bathroom, because sure, when they get in here and get that, they'll steal toilet paper too. They always steal toilet paper. Look at that. See, the roll's empty again. They come in here and he thinks I'm not nuts, because I saw that it's gone. Well, I'm going to go down to the corner store here and get some toilet paper, because there's nothing worse than constipation and you got to go and there's no toilet paper. You got to have some. So I go down to the corner store and I pick up a few things that I need, because I know there's some things I need. And I come back and I go to put them in the fridge and such. And there's another quart of milk in there. Well, I wonder who brought that by. I don't know when they brought that. Well, good. I can make use of it. It'll be fine. And let me go put this toilet paper up. You know, I'm not going to put it in here, because sure as hell they'll steal it just like they stole the other stuff. I'm going to go put this in the spare bedroom closet, because they won't think to look there. Okay, here we go. Oh my God. This is where they're keeping it until they can bring a truck to come pick it up. There's got to be 30 rolls right there. I'm going to hide it under the bed. They won't know where to look for it. At 10 minutes after 2, the telephone rings. Hello? Well, hi there. How are you? What do you mean, where am I? I'm at home. Where are you? Well, what are you doing at the mall? Well, if you wanted me to come to the mall, you should have called me. I can't read your mind. What do you mean you did? Who'd you talk to? No, I didn't talk to you. I don't remember if I talked to you. I hadn't talked to you in, I don't know, a month or so. You did not call me. Maybe you called the other one. Listen, I mean, I hate saying this, because I hate even bringing it up, but I think you best go see the doctor, because I think you may have that dementia they talk about, because I think you're all turned around, sweetheart. All right, well, bye-bye.
Okay. Tipa is really entertaining. Let us switch to, where'd it go? There we go. All right, not normal aging. So in this second scenario, Tipa was unable to successfully place her friend Betty. When she got the phone call, she said, "Hi. Yeah, who is this exactly?" She didn't even remember or recognize the voice. So she said, "Who is this exactly?" Unable to successfully place a person, she didn't even try. Personality or behaviors will be different. Well, why didn't you say that in the first place? You know, she's kind of being aggressive, being mean, or the opposite might happen with somebody else. They could be really sad and not bashful. It's more like scared. Sometimes they're like really scared. So they could be really mean, they could be really scared, they could be normal personality. It's just that you will see a difference in behaviors. Unable to think the same will get stuck in a moment of time. So in this second skit, Tipa, she couldn't relate Macy's to JCPenney's. She said, "No, I'm sure it's a JCPenney there. I got a credit card there, I just shopped there." You know, like she was adamant that JCPenney's was still there. She was confused between past and present, and she was stuck in that time when it was JCPenney's. It can't be anything else because that's all I know it as in her brain. Unable to think things out, she can't even, or she wasn't able to, you know, like attempt to say that Macy's might be the new JCPenney's. She was unable to think that out, and she was just stuck. Circumlocution, difficulty describing objects. So this time with the coconut, instead of, you know, we talked about nouns popping up, coconut, instead of her saying, "Oh, the white flaky stuff," you know, trying to pop the noun up, she did a wider circle around that noun, so around coconut, instead of using things that are almost relatable, white flaky stuff with the chocolate, to the brown hairy ball thing. The brown hairy ball thing that you like. And people with dementia, that is their best way of communicating. Remember, language is lost. It's really difficult to understand the brown hairy ball thing. But if you imagine a coconut that fell off a tree, right? It's green, turns to brown. When you husk it, it's brown. It's kind of hairy. It's a ball shape. So a brown hairy ball. The brown hairy ball thing that you like, the coconut that you like. I'm saying coconut, why can't you understand? Language is lost. And that's what circumlocution does or describes. Lack of impulse control, cannot see the other person's perspective. Sorry. Lack of impulse control, cannot see the other person's perspective. So even in the beginning, she was saying, you told me on bridge? I don't know, you talk a lot at bridge. Your mouth just runs incessantly. She lacked the impulse control. She wanted to say it, so she said it. She cannot see the other person's perspective. Well, I don't know what you're getting all mad for, you know? So these behavioral personality changes, it's mostly due to a lack of impulse control. Because if it were you and I at the grocery store and this woman was extra large and in charge, then hopefully not, but I could like whisper it into my friend's ear instead of saying, wow, she must have ate 3 hot dogs, a large Coke, you know, just like throwing out a fat comment. But I would have the impulse control to be discreet. A person living with dementia can't see from the other person's perspective. She just says, this is my opinions. I don't really care what you think. Unfortunately, that's just dementia. But words won't even come with visual, verbal, or touch cues. So with that, after the phone call, she saw the coffee mug. She saw a visual thing. She said, a coffee mug, a coffee mug. She touched it. But what did she think next? Did she think, I came here to get coffee? No. What she did is went to check her toilet paper to see if her toilet paper was there, because the gypsies came and they steal her toilet paper. And if they steal that too, then she better go pick up more because, you know, and that has to do with confabulation as well. Confabulation is bridging their or our reality to what they believe. So a person living with dementia will really believe that gypsies are coming in to steal my things, when in reality, she's just losing it. She's misplacing things. And it is a dementia that's causing her to misplace these things. But we as caregivers need to understand that that's what they believe. My grandma's the same way. She, what did she do? She misplaced a cookie sheet. You know, like a cookie sheet, you make 12 cookies in the oven. And she blamed my cousin. And my cousin did not lose it or misplace it or use it at all. He doesn't even touch the oven. But she blamed him because maybe he's been doing sneaky things lately, sneaking in at night, late at night to avoid getting caught. I don't know. But she acquainted him to be stealing it when in reality, she misplaced it. She probably, like Tipa Snow, put it someplace else, and maybe not under the bed. It could be like on top of the washing machine, instead of its usual place, because that's where the gypsies will take it from. They know I put it there. And recently, my grandma's been displaying more of that. She blames somebody else, not the gypsies. I'm not going to mention it because the right side also holds racist stuff, racial slurs, swear words. And so she's retained those, and she don't call them nice things. So I'll just say her frenemies are stealing things, and she keeps blaming them. My uncle is just like, no, you lost it. And she's like, no, they came in and stole it. Why don't you believe me? I don't know. It just gets bad. But that was not normal aging. So if you see any of these symptoms, that is not normal aging. And bottom line is you should get an assessment done to figure out which dementia it is. Because if you figure out the specific dementia, it's easier to understand the progression of it, so you can combat that with the positive approach to care. Now we shall talk about the 5 senses and how humans take in data. and I got 5 minutes. Okay, so we have 5 senses: what you see, what you hear, what you feel and touch, and what you smell, and what you taste. We will be focusing on the first 3. And the first 3, what I understand is that that is the way that humans, aging normally or not, that is the order, the sequence that we prefer to take in data. So put up your thumb. We're going to close one eye, extend your arm, and pretend you're an artist. Look around the room. Vision. The first sense, your thumb, is representing vision. And we'll remember that by pretending to be an artist. So vision is king. We want to see before anything else. We want to see what's coming at us. So we need to know if we need to run, duck, hide, throw the next guy in front of you. You want to see what's going on. For example, if you hear a big boom in the back, what is the first thing you do? You look. If you're in the ocean and something brushes up upon your leg, what's the first thing you do after you scream? You look. You want to see what's going on. Second one, your index finger, bring it to your ear, what you hear. So auditory data. We want to see first, then we want to hear what's going on. We want to see and hear what's coming at us, what's approaching us. And as caregivers, what do we like to do a lot of? We like to talk. So like I said, language is lost. If you're talking, the funny thing with dementia is that they lose content, but they hear the rhythm of your voice. They lose the content, they retain the rhythm. So in the beginning, you can understand 5 out of 5 words that I'm saying. So if you miss a word, you might still understand what I'm saying. What do you want to eat today? Want to eat today? You can understand. I'm trying to ask you a question. You lose 2 out of 3 words, maybe, depending on the context. 3 out of 5, 4 out of 5. If you lose 5 out of 5, they will start to hear the rhythm of your voice rather than the content. So with dementia, it's important to use this positive approach and see how humans take in data and what we prefer. So the first one is vision. The second one is hearing. And the third one, take your middle finger and drop it down to the back of your hand. That is sensory motor, what you feel, what you touch. If you feel something and you like it, you do more of it. If you feel something and you don't like it, you stop. What you touch and what you feel. We won't really get into smell and taste, particularly because we're not using those senses. But I wanted to impress upon you that it is important that we remember these 3 things and the order that they come in before we touch the last one. Because if you start an interaction, there's an activity that I would do, but it's better if we're in person, and you need a partner, so we won't do it. It's just that make a note of no touching until you've done a visual and verbal. Visual is really key so that you don't startle them, because if you just talk loudly, they're gonna jump. They didn't see you there. They didn't see you there. So visual, then you say something before you touch. Touching is the most intimate, sensitive part of those 3 things. Don't do to someone. We want to do with them. Dementia robs skill before it robs strength. That's why caregivers provide the skill. And use hand under hand to support. I have another video I want to show of me and my friend Sarah acting out this hand under hand technique. And I think we also do the positive approach, which is pretty important. So perfect. I blazed through that in 5 minutes. I hope you understood that. I think I will show you the video now. Read over. Nope. Okay, one more slide. This is the building skill part of our webinar. So build skill. There's a positive approach, or so many P's. A positive physical approach where you will actually physically walk and approach somebody positively. There's supportive communication that we can use to build skill, consistent and skill sensitive cues. So using visual cues, using verbal cues and touch cues appropriately. There's hand under hand, which is this handshake that you see. And we use that for connection and assistance. So we can use it for eating. I wish I had a partner to show you that. We can use it for assisting them, for walking, for brushing their hair, personal care. And to build skill, we need to have an open and willing heart, head, and hands to give care. Approach matters. Okay, so this is how to use the positive physical approach. I'll just glaze over it. Pause at the edge of public space, about 6 feet or more away, public space. You want to pause. Gesture and greet by name. So of course you want to be in front of them. Vision, you want them to see you first. Pause in front of them. Gesture with your hand. Hey, hi, greet by name. Hey, Mapu. Offer your hand and make eye contact. With this approach, you're going to do a handshake, a regular handshake. That's how we normally say hi to each other. Make eye contact. Approach slowly within their visual range. You're going to shake hands and then switch into this thing called the hand under hand. You're going to move to the side of the person living with dementia, get down to their eye level, respect their intimate space, how close and far you are from them, and you wait for acknowledgement. It's harder than you think. Okay, so this video is of a workshop that Sarah Tomkisen, she's a VA social worker. My other friend, Gina Hishiki, she works at 15 Craigside in the dementia or healthcare unit, they call it. And we did a workshop at 15 Craigside. Here it is. I wanted to show you, because I don't have a partner today, I wanted to show you with a partner how to positively approach and the hand under hand. And I have a fake hand, so I can kind of show you the hand under hand. It's kind of important, and that's your takeaway tool for today, something to use, because you can use it on anyone, 5-year-old to 95-year-old. It's a handshake that supports the person that you're interacting with. Okay, I'll shut up. Again, might have to adjust your volume. Sorry if it's too loud.
We are okay, we're gonna get started now in our next section with Mapu. Mapu's gonna do the use of hand under hand. So these are one of the techniques that that teaches us. Okay, so the hand under hand technique will come in a second. I wanted to briefly show you how to positively approach somebody using vision, then auditory, and then touch. But it'll just be short because that's in our next workshop. Okay, so we're going to pretend that Sarah is a person living with dementia, and I will positively approach her. So what you want to do first, as a caregiver, is stand about 6 feet away. That's called public space, so approximately 2 arms lengths away. And then in this public space, it's acceptable for us to greet. Not necessarily start a conversation, this is still a little ways away, especially if we're at a family function or so. But we greet each other with a normal hello, how you normally would. And then I got her visual attention, I'm in her visual field, so we accomplished the first task. The second one is talk, or auditory. So once I got her attention, Sarah. Hi. So if she's distracted looking away and I say, Sarah, hi, and she can hear me, then she will look towards me and I got her attention. And why we use a big flat hand, it's pretended is a target. So that's where I want her eyes to come. And since it's right next to my head and my name tag, she can see that once she hits this target, who's talking to me? Oh, it's Mapu. I know that because her name tag's there. You may or may not wear a name tag. I know one of our resident families, he came to our workshop, and after learning this, he came with a sticker tag every time. And he used that, he was hi. And his wife would say, Rob, it's pretty cute. Yeah, that's pretty awesome. But, so I get her attention, Sarah. Sarah, hi. Hi. And how do we normally greet somebody we meet for the first time? A handshake. And that's exactly what I'm going to do here. Try to make it as normal as possible. So get her attention, and I want to come in for the handshake. And if she reaches out like this, If she reaches out like this, that means I can touch her. I've got her attention. If she reaches out, I can touch her, so I go into the handshake. If I come in and she just has her hand down, that means don't touch me. I don't want to be touched. I don't know you yet. I don't trust you. And that's a different approach, slightly. But we're gonna say that she likes me and she's gonna touch my hand. So we go in for the hand touch, shake for a little bit, and the first thing we wanna do is let go. But as a caregiver, I wanna maintain that connection. I don't wanna let go. So we use the hand under hand technique. After you physically approached her, you got her attention, she likes you, she lets you touch her. You shake for a few times, and then you go switch your hand up into a butterfly or bird position, and then you just gently wrap your fingers around. And since I'm coming from the front, I'm still coming. This is just super slow motion. And I want to come to the side in a supportive way. If I stood in front of her, it's more confrontational. And in our second workshop, you'll learn that vision, it kind of comes into this tunnel type of vision. So I can't do it, but imagine I have snorkels on. So,
start with mask. When we start to, lose our vision, and not sorry, when we start getting dementia, we start from here, a mask, and from there it turns more binocular. Now, if you were to put your hands here like binocular, you'll notice that you can only see in front of you. Can you see peripherally or to your side? No, probably not. And then as the progression of the disease continues, eventually you can only see like slight little monocular vision.
Yeah, so if you use that snorkel vision and you look at your partner next to you, you see that they are taking up your entire visual field. And for a person living with dementia, that's very threatening. They don't see a way out, so they might also start freaking out or getting startled. So I have her in the handshake and she has her snorkels on. Instead of standing in front of her, this is confrontational stance. I'm gonna come to the side. And if you have your snorkel mask on, she can still see me, but there's also a way out. So in my visual field, if I can see this much, I see her in this much, and then this is my way out. Question?
How about if the person with dementia is in a wheelchair, you're coming at them, will you crouch down to get your eye level?
Yeah, that's a good question. Yeah.
Yes, so it depends. You want to come down to their level. And for me, I love to be under their eye level. It's more of a submissive thing. So like you say, if Sarah's in a wheelchair, I wouldn't stand over her like this. Interesting. But I wouldn't stand over her like this because it might even hurt her neck. I would come down to her level. And if you don't have young knees, you might want to grab a chair and bring it close to her. You can bring a chair right next to her and sit next to her so that you're at or below eye level. They accept you greater that way. I tried that on a 3-year-old once. Wonders. Then you offer her grapes. So if Sarah's seated, I came in from, okay, so she really can't see me. If she, I don't know, has a neck impairment or something, she can't look up, and I want to physically approach from the front.
No, I'm playing with some.
Well, I would come all the way down here and try to get her to my target. Sarah, hi. You wait a little bit so that she can see you, and then you bring out your hand. Hi, Sarah. We switch to the hand under hand, and I'm at her side now. So supportive stance with the hand under hand. Let's partner up now. We'll practice the hand under hand.
Okay, cool. Oops. So that was the hand under hand and the positive physical approach. Skip over. And we're almost done. Oh, snaps. I only got 5 minutes. Okay. Video me. So, in summary, we're going to keep it simple. Use visual, then verbal, and see if they want to touch before you do with that handshake. Extend your hand, and if they don't take you back, then you just kind of have to stay at a, at a distance. Stay at a distance, get low, and still talk to them. I really want to show you this before you go. So I hope this is okay. This is my pretend hand. I just traced my hand, cut it out. So I want to show you the handshake. You go in for a regular handshake, right? But instead of letting go, you're going to kind of go up, and you wrap around and like that. And then the caregiver's hand is on the bottom. So let's try again. Find a partner tonight if you can, right now, and practice. This is your take-home tool, the hand under hand. So go in, regular shake, slide up and over, and caregivers on the bottom. And from here, we can if I'm the person living with dementia, I'm on the top. So they'd be supporting me, and you can help me eat. This is comfortable for both parties. You can help me eat. You can help me brush my hair. You can fix my shirt for me, all by keeping connected. This is a really important tool. Wrap around. I just really want you to practice it, and I hope this demonstration made sense. One more time. So you can practice. So go in for the regular handshake. You're gonna slide up, and you have to do this. They're not gonna do this. You can't teach them it. I don't think so. You can try. Wrap around. So handshake, fingers open up. It's kind of like a bird, butterfly, and then wrap over. Person living with dementia is on the bottom. No, on the top. Sorry. Caregivers are supporting. That's how you'll remember. Caregivers on the bottom because we support the gem on top. Okay, 2 more minutes. If you have questions, then you can do it in the chat. I have a poll just to see how I did. I will launch it now, and feel free to take it or not take it. I don't need to show you the results if you don't want me to. But other than that, I have a few more things I'd like to introduce in the 2 minutes I have. Oh, shucks. Looks good. Okay, so when words don't work, hand under hand helps. It establishes nerve pathways, allows the person to feel in control, connects eye-hand skills, use the dominant side. So if the person is left-handed all their life, you need to approach on the left side. The gems are something that Teepa Snow, I want to say invented, created. She used the Allen cognitive levels of dementia and transformed them into what she calls the gems, because gems are much more appealing than your mom is level 3 dementia. Your mom is mild severe dementia. She uses gems, sapphires, diamonds, almonds, emeralds, ambers, rubies, and pearls. And they all have different traits, and they all are different levels of dementia. I think this is my last slide. So in summary, people living with dementia need care partners to think and act on what they want, need, and think. What they want, need, and think, yes. It's a brain impairment. Now caregivers are in control. It's kind of like having a 3-year-old again. They have curiosity. They want to run across the street and get their ball or see the dog. They don't have safety awareness of the car coming at them. Similar with dementia, they can cook. I'm an adult. I know how to cook. But they forget to turn off the stove. Safety awareness. Watch and observe. As caregivers, we are detectives now. What they show you, how they look, their reactions, their facial and nonverbal, what they say, how they sound. Do they sound afraid? What they do, their physical reactions and behaviors. Watch it all and observe. Is it a pattern? Is it pain? Is it because she's hungry? It's just like a baby. Why is the baby crying? She's hungry. No, babe, that cry is because she peed her pants. You know, you know these things. You watch and observe. You take notes. Anyway, there seems to be no questions. Thank you for coming and have a great day. HPGS webinar. Next time we will have it on, oh man, the last Thursday of every month at 11:30. I will send you an invite. It is April 26th. Be there or be square. I don't know the topic yet, but we will email you. Thanks for coming. This has been fun. Bye.